Good morning, everyone, and welcome to this session of the 2024 Culture of Data Conference. Thank you all so much for joining us. I'm hoping none of you had any snafus trying to get into this session. My name is Ann Hill. My pronouns are she, her, hers, aya, and I will be moderating this session. And we're also really lucky to have Taylor Bostic. Her pronouns are she, her, hers, aya, who is she's going to be managing the Zoom and making sure that the tech is running smoothly throughout this particular session. You're all muted right now, but if you do have a question during the Q&A session, which is at the end, we just ask that you unmute or put your question into the chat. Right now, we ask that if you feel comfortable that you change your pronouns, and you can do so by clicking into the 3 dots on your video square and then selecting rename. For this particular session, we only have one presentation, and they will present for approximately 25 minutes or so, and then there will be a 10-minute Q&A afterward. The presenter will be describing innovative practices to address data inequities and collect more meaningful data, strengths-based data, to advance health equity. Baby and You, which is a program with CDPHE, is increasing inclusion by sharing power and changing its advisory structure to include more diverse voices. We're really lucky to have Sarah Blackwell, and she will be presenting Baby and You, a commitment to data equity to advance health equity. Sarah, I'm going to turn it over to you now.
Thanks so much, Anne. Let me just pull my slides up real quick. All right, can I just confirm that everyone can see that? Excellent. So hello, everyone. My name is Sarah Blackwell. My pronouns are she, her, hers. I'm the Baby and You Program Coordinator at the Colorado Department of Public Health and Environment. Baby and You is an online longitudinal survey program for postpartum people. And today I'm going to be sharing with you our commitment to improving data equity within this program in order to collect better information to advance health equity. During my presentation today, I'm going to set the stage by describing the basics of data equity and the principles of it that we're applying within our program, provide some background on the Baby and You program and our unique opportunity to do things differently with this data collection system, and describe a little our efforts to make this a more equitable data system, focusing primarily on our efforts of inclusion, both within our survey sample and in our program decision-making. And also, I have a tendency to speak quickly, so if I'm ever going too fast, feel free to drop a reaction. You can pick the turtle emoji, and I will make sure to slow down. So data equity is the concept that our data collection programs are a product of the same biased systems that create health inequities. As such, they are embedded with power, privilege, and dominant culture values across every stage of data collection, the entire life cycle that is depicted here. For many of us data folks, our power to advance data equity is limited to the analysis and later stages of the life cycle due to using only secondary data or due to the inflexibility of some of our large-scale and long-standing data collection systems. And although there's still great value in this work and advancing equity within any of these stages is worthwhile, without improving data equity across the whole data collection life cycle, our data will continue to be limited in their ability to advance health equity. There are many different conceptualizations of the core principles of data equity. The Public Health Institute at Denver Health, for instance, has a really great summary of their data equity principles and approaches. However, as we do this work, we keep identifying additional guiding principles that don't quite align perfectly with those existing lists. So we've started our own that we intend to continuously add to. If there are any other principles that you would like to add from your experiences, I encourage you to drop those into the chat and we can make sure to integrate those as well. So the first of our data collection principles is scrutiny, which is a commitment to recognizing and challenging systemic bias and isms at play across the entire data collection lifecycle. We are also very focused on inclusion, increasing representation both within our data collection and within program decision-making. And part of this is a commitment to shared power. which is allowing community voice and power to shape our program to the greatest extent possible. Another principle of ours, oopsies, sorry about that. Another principle of ours is reciprocity, recognizing that data collection is inherently extractive and identifying every possible opportunity to give back to our participants and to those collaborating with us. Another principle is transparency, being clear about what power we hold and what power we can share and what we cannot. Accountability, doing what we say we're going to do, demonstrating how community voice has shaped the program, and providing explanation for when we can't be guided by community needs and voice. Another principle of ours is community strength, which is acknowledging the deep wisdom and strength that lies within communities themselves. This applies to respecting community voice and guidance, as well as the need to collect data that identifies and honors and finds solutions that are rooted in community strengths. Additional principles that we hold are autonomy and privacy, allowing individuals and communities ownership of their own data and stories, and safeguarding those stories from misuse and distorted lenses. And finally, or not finally, since this list is not exhaustive, is sovereignty. We do not own these data. We are merely the vehicle for their collection and a steward for their protection. We will do our utmost to, in particular, honor tribal data sovereignty across the data lifecycle. We have a unique opportunity to apply these principles across that data lifecycle with the Baby and You program, which is a maternal and child health data collection system that only exists in Colorado. This program first started as Healthy Moms in 2018, and it started with seed funding from the Colorado Health Foundation, and then was sustained through 2021 by a patchwork of funding from across CDPHE programs, our sister agencies, and the Zoma Foundation. The pandemic jeopardized some of these funding streams, and so the decision was made in 2021 to sunset that program. And shortly after its sunset, partners who had come to rely on our data for many different purposes advocated for Healthy Moms to be added to a Medicaid bill, and that Medicaid bill passed in May of 2022. This gave us the opportunity to revive Healthy Moms as an even better and more equitable program than it was before. Under House Bill 22-1289, the program, which was rebranded as Baby and You to be more inclusive, now has an explicit equity focus in collecting data to inform programs and policies that advance health and health equity for postpartum people and their families. As part of this, the program is required to intentionally include or oversample in data speak, although we're trying to move away from that language as it can be dehumanizing. So we're required to intentionally include American Indian and Alaskan Native and Black or African American birthing people. And in order to do this, we now receive dedicated funding at a higher dollar amount than we previously had for Healthy Moms. And under this legislation, we have some required content areas that help ensure that the data that we are collecting is supportive of the Medicaid programs included in this bill. After receiving funding in July of 2022, we were able to restaff and relaunch the program by spring of 2023. So as part of Baby and You, we are randomly selecting about 3,400 postpartum people each year from birth certificates, which is around 280 each month. We draw monthly samples, and we invite those folks by mail to join our online survey platform. Our primary recruitment contact is a branded box that includes a program brochure, an informed consent document, some branded swag, and a sticker on the inside of the box lid that has their unique login information. Participants access the survey by scanning a QR code and entering a 4-digit PIN that allows for all their eligibility information and survey responses to be tied back to the information that we have on the birth certificate, which is quite extensive. It's far more than a lot of people know. There's a lot of clinical and demographic characteristics recorded there. Participants complete the first survey at the time of enrollment, which is about 3 to 4 months postpartum. Then they are contacted by email and text message to complete additional surveys around their baby's first, second, and third birthdays. Each survey takes about 10 minutes to complete, and participants receive $20 gift cards for every survey that they take. And since we draw our sample from the birth certificate, we're also able to weight our Baby and You responses to be representative of all eligible live births in Colorado. Although we carried many Healthy Moms methods forward to Baby and You, there are some key differences. With Healthy Moms, we drew a simple random sample, which means that the distribution of demographic characteristics within our sample was similar to the distribution among a full year of birth records. With Baby and You, we performed stratified random sampling, which means that we first break up our birth certificate records by race and ethnicity in order to draw disproportionately large samples from historically underrepresented racial and ethnic groups. Since this shifts our sample to harder to reach populations, harder to reach in part due to the historic harms of research and data inequity, we have also increased our sample from 2,400 each year to 3,400 each year. We also now have 2.5 full-time employees dedicated to this project when previously it had been a program of 1. This includes myself, our analyst, Juan Vasquez Jr., and some additional time for admin help. This is made possible by receiving consistent funding of $500,000 each year to sustain the program. And another change that we have made that I will talk about more a little later is that we've also changed our advisory structure from a closed advisory board of primarily professional partners to an open advisory network that intends to broaden representation of lived and professional experiences and expertise within our program decision making. Now I'm going to dive a little bit deeper into how some of these new efforts are going, starting with intentional inclusion of historically underrepresented racial and ethnic groups within our survey sample. So in order to perform intentional inclusion or oversampling, you first need to break up your population into mutually exclusive categories according to your stratification variable, in this case, for us, race ethnicity. And I want to stress that although we do this for sampling, we know that racial and ethnic identity is often not mutually exclusive, and that this level of aggregation is unduly homogenizing. So this is not how we intend to analyze the data. This is just how we have to break up the population in order to oversample and also have an affordable sample size. So for purposes of sampling, we settled on 5 categories: non-Hispanic American Indian Alaska Native, non-Hispanic Asian Pacific Islander, non-Hispanic Black African American, Hispanic Latinx, and non-Hispanic Other, which includes our white population. On the left, you can see the distribution of these 5 categories within the entire birth population in Colorado. And this would have been the distribution that we observed in the Healthy Mom sample, which resulted in insufficient information to disaggregate data for all but the Hispanic Latinx population and the non-Hispanic white population using a single year of data. On the right, you can see the distribution of these categories within the Baby and You sample. And although the legislation only required intentional inclusion of American Indian, Alaska Native, and Black African American birthing people, we've also included an oversample of Asian and Pacific Islander birthing people to try to achieve balance across all of the OMB minimum race classifications. And as you can see, the pieces of the pie are much more evenly distributed now in Baby and You. We're nearly finished with data collection on Baby and You Survey 1 for the 2023 birth cohort. And these are the response rates that we've observed for January through November births compared to those that we were expecting based on what we observed for Healthy Moms with these sampling strata. So in all groups, we are actually exceeding our expected response rates. Our overall response rate for Survey 1 is about 47%, which is comparable to what we had in Healthy Moms. That was within 1 percentage point of what we had with Healthy Moms. And we had expected a drop in response rates due to shifting our sample towards harder to reach populations, but we suspect that this was offset by the introduction of the QR code with Baby and You. For Healthy Moms, we had used a keyword texted to a short code, which was more common at the time. But since the pandemic, the use of QR codes has become much more common. And so we think this gave us a boost when we were expecting to have a drop. So in some cases also, our lower anticipated response rates may have also been affected by the small sample sizes and greater variability in some of these populations within Healthy Moms. And although this is actually a very high response rate for a web-only survey, we aim to get these even higher through our other inclusion efforts by making our surveys more relevant to these communities. Based on the 2023 data collection thus far, we anticipate having over 1,500 Survey 1 respondents in each birth cohort. Among those responses, we expect to have over 100 participants who identify as non-Hispanic American Indian Alaska Native, nearly 300 respondents who identify as non-Hispanic Asian or Pacific Islander and non-Hispanic Black African American, over 400 Hispanic and Latinx respondents, and nearly 500 non-Hispanic other respondents, which is largely the white population. And just to provide a point of comparison, Healthy Moms only included around 10 American Indian Alaska Native respondents per year and about 30 respondents, which is right at our threshold for suppression, who identified as non-Hispanic Asian Pacific Islander or non-Hispanic Black African American. So this is a dramatic improvement in the representation within our data. So this means that for survey 1, we will be able to disaggregate our data for all of the categories that you see in column 1 on the left with just a single year of data. With 2 and 3 years of data, we'll be able to disaggregate even further for the Asian population. And then also, we're not here yet, and we only will get to this point if we get permission. But with permission and with restrictions on how the data are used and shared, we theoretically could also disaggregate the American Indian Alaska Native population by tribal affiliation, since that detail is collected on the birth certificate. But once again, that's only something that we would do with the permission of the tribes and our American Indian Alaska Native serving partners. Additional dimensions of race and ethnicity that could be considered as well with these data are looking at any of these individual races in combination with any other race or ethnicity. So you might be familiar with how you see data on the census, where it's a race alone or a race alone or in combination with any other race. So we could do that with these data as well. We can also integrate whether someone is foreign born versus US born as an additional dimension. And also we can bring in whether the person indicated that their preferred language of communication was Spanish on our surveys. So although we are successfully including more birthing people from historically underrepresented groups, this is not sufficient for equitable data collection. If we're collecting more data, but those data are still embedded with the biases and dominant culture perspectives, then this data may still continue to do more harm than good. We must also seek to collect more meaningful data that reflects the values, strengths, and cultures of the diversity of communities that we hope to represent through this intentional inclusion. So in addition to inclusion within our data collection, we're also doing our best to share power in decision-making for all aspects of the program. Since we no longer have to chase funding by selling survey space, we're also democratizing the survey development process so that community interests and needs can drive our survey content. We're exploring ways to emphasize strengths and assets, not just challenges and deficits. We're also going to include community members and partners in how we interpret, contextualize, and act on the data that we're collecting. We're building relationships so that we can be responsive and flexible to the data needs of community partners and tribes, and lend our capacity to analyze and frame data in ways that are most helpful to them. We're also working to make tribal data sovereignty a forethought and not an afterthought in the collection of these data. To highlight some of this work, I'm now going to describe some of our efforts to improve inclusion within our survey development processes and also within our broader program decision-making. I'm going to start with the survey development of our 4 surveys over the first 3 years postpartum. And just as a reminder, here is our survey schedule. Participants receive surveys at 3, 12, 24, and 36 months postpartum. We ask some questions just at one critical point in time across these 4 surveys, and other questions across multiple surveys in order to understand how individual experiences and family experiences unfold over time. House Bill 22-1289 requires that we ask questions related to these 6 content areas, but it gives us a lot of flexibility in what we ask and how we compose our surveys. With about 240 questions across all 4 surveys, this still leaves us a lot of space to collect additional data that can be almost entirely driven by partner and community need. Now that we have dedicated funding, we can do open calls for proposals for either specific questions or general concepts that people would like to see on our surveys. We want it to be as friendly to different types of experience as possible, So that's why we allow just concepts to be proposed as well as specific questions, which might be more within the capability of professional partners. Anyone can submit a proposal, and no funding currently needs to be attached to a proposal for it to be accepted and for those questions and concepts to come to fruition in our surveys. Our proposal form is open continuously, but we periodically have deadlines for submission for the development or revision of a particular survey. Our next call for proposals, this one for survey 3, which is delivered at 24 months postpartum, will be coming up this June. Once we receive all proposals, they are anonymized, and the Baby and Youth Steering Committee considers all proposals based on their breadth of benefit, their potential for advancing health equity, their actionability, and the available space that we have on the survey. Surveys 1 and 2 are the only surveys that are already in the field, and here's a summary of the topics on which we're collecting data. If you see something missing that is a priority to you or your community, I encourage you to reach out to me and submit a proposal for survey 3 or a revision of one of these existing surveys. If you see a topic area on which you've desperately wanted data or just that you're excited about, also reach out. We're going to have our first year of survey 1 data available later this summer, and our first year of survey 2 data will be available early next spring. Share a little bit about how this process went for the development of survey 2, which we completed this last January. We were able to accept 11 out of the 20 topic area proposals that we received. We created 11 work groups based on these proposals that included the person who submitted the proposal, anyone with lived or professional experience or expertise that they wanted to be included in the process, subject matter experts on those topic areas from CDPHE programs, and anyone who had signed up through our partner advisory network to be part of survey development on that topic area. And I'll talk a little more about that advisory network later. These groups had a combination of virtual recorded meetings and opportunities over email and survey to provide feedback and to collaborate on the development of these question sets within those topic areas. Once question sets were developed within those groups, all work group members were invited to test, review, and provide feedback on the full survey. Although we know we still have a lot to learn and improve with this process, we're very encouraged that on our evaluation, one of our partners felt that this was a truly community-centered process, and that is definitely what we are going for. The majority of the participants in our survey development process felt that their perspectives were respected and helped to shape the content of the survey. They also said that their time was well spent and that they felt that meetings were productive and had good communication. However, we also learned many things that we could improve, such as dedicating more time to the process, especially on those topic areas that are novel and just emerging. We also need to be providing more resources and templates to help folks develop proposals, and that is something we are putting together now. We also know that we need to have a flexible process that's based on a variety of participant backgrounds and preferred styles and really tailor it to the people at the table in each work group. And also we need to conduct more concerted outreach of community-based organizations to be part of this process. And that is something we are definitely committed to doing, but also something that we hope naturally develops as we do more community and organization relationship building over the next few years. Another effort to increase inclusion in our program decision-making is transitioning from an invite-only advisory board, like we had with Healthy Moms, to an open partner advisory network that allows for a greater balance of professional and community voices. So those voices can weigh in on programmatic decisions that are relevant to them when they have the capacity to do so. With this approach, we're not limiting the number of seats at the table or requiring folks to have consistent capacity to participate. However, we know that this is a more inclusive process of a greater variety of partners. It's still going to draw more professional partners than community members and doesn't provide a clear-cut way to compensate community members for their time or people who represent community-based organizations for their time. So we're also planning on complementing this work with key stakeholder meetings and periodic focus groups among our priority communities. If you're interested in joining our partner advisory network, you can sign up using the QR code here. Anyone can join and specify their program decision-making areas of interest, their topic areas of interest, and whether either they represent an organization that serves our priority communities or identify as a member of one of our priority communities. And I can come back to this slide if folks don't have a chance to scan the QR code. We're beginning our more concerted community engagement efforts among the American Indian Alaskan Native population. We're working with Project Mosaic, which is an Indigenous-led consultancy based here in Denver, to develop short and long-term community engagement plans. As part of this, we recently held a strategic planning meeting with American Indian Alaska Native serving organizations to discuss how best we could support them in partnership, provide value to their organizations through Baby and You, protect tribal and Indigenous data sovereignty, and collect data that is more culturally meaningful. We're also conducting focus groups with Native parents. The first one is actually tonight, and we have a second in-person one scheduled for this Saturday to discuss how we can make our survey materials more appropriate and inclusive of them, and how our surveys can reflect their priorities within the perinatal period, as well as how our surveys could be used to emphasize and identify community and cultural strengths of Native families. And an additional aspect of that is that although we have these four core surveys in place for everyone now, in the future, we hope to identify additional sources of funding so that we can have community-specific supplements that are entirely driven by community need and what we identify in these focus groups and with stakeholder meetings. So on all of these efforts, we're coordinating with our tribal relations team here at CDPHE in order to make sure that our approaches are culturally relevant and respectful and timely.
Sarah, just where you have about 2 minutes.
Okay, I think we're perfect then. I have 2 more slides. So we intend to develop similar plans for all of our other intentionally included priority communities. And we want to make sure to do this with respect for the interest, capacity, time, and wisdom of our partners. For instance, we're coordinating with CDPHE's maternal health team, which has many of the same priority communities, partners, and a similar desire to incorporate community voice on similar topics. So we're making sure that we are working together so as not to overtap these groups that already have limited capacity to engage in this work. So just to summarize, this is definitely not an exhaustive list. We have much more to learn along the way, but some of the lessons that we've learned so far as we're taking the first steps down this path are that this work will take time. It's not a checkbox or a discrete outcome, but an ongoing process. We can celebrate incremental progress, but we should never settle for it. The goal is substantial change in how we're doing things. We also need to be flexible and responsive. No approach should be fixed. We're trying to represent a great diversity of people, and so we'll need a great diversity of approaches to make the system inclusive of all. Transparency and consistency in action and communication are key, and really the only way to build and earn trust, which should never be taken for granted. And I think that was my last slide. So thank you for your time and for choosing to kick off the conference with this session. I look forward to your questions, and I really hope that I can collaborate with you, some of you in the future, on making this a more equitable program.
Thank you so much, Sarah. That was fantastic. We are now going to open up our Q&A session. So we encourage all of you to either unmute and present your questions to Sarah, or you're welcome to put the questions in the chat and we can read them out.
I have a question, but looks like there might be one in the chat, so I'll elevate that first.
Are you okay with that, Dennis? Yeah.
Absolutely.
Okay. So Kelly noted, she says, I'm wondering to what extent you already collect information on postpartum mental health and if there are plans to expand the collection of that data. PSI has just launched the Colorado Perinatal Mental Health Project, and this might be a great collaboration if you aren't already connected.
Yes, we collect a substantial amount of information on postpartum mental health. In a second, I can get our survey domain spreadsheet that quickly summarize in a digestible way all the questions we have on Survey 1 and Survey 2. but we collect information on experiences of post-natal depression, anxiety, social supports they had, comfortability talking with different types of healthcare workers about their mental health, whether they wanted or needed mental health care or counseling services, whether they received them, barriers to receiving them, and just many other like social factors surrounding one's mental health. And so after we go through questions, I'll try to quickly grab that link and drop our survey domains in the chat so you can see that more specifically. And we have had a longstanding relationship with Healthy Moms and working with folks working on PSI, used to be the Perinatal Depression Task Force, I think. I think that name has changed since. But we have had lots of collaboration around that, and with now the Maternal Health Task Force, but just definitely relationships that we want to continue. But that is one of the focus areas that we collect on every single survey so that we can understand changes over time and what might mediate and moderate improvements or worsening mental health.
Thank you. Dennis, do you want to ask your question, and then I will get to Alexa and also the additional questions in the chat?
Sure thing. Here, let me press a button. Thank you so much, Sarah, for walking us through that. I loved hearing about the program. And one particular piece that you raised was reaching out to more traditionally difficult populations to collect data for. And I'm thinking of some of these smaller population, well, not, I don't want to say smaller, just populations that deserve their voices to be heard as well. I'm thinking of the American Indian Alaska Native voice or some other small demographics, however you want to phrase that one. Typically, a lot of the work to end up with data with that group is through trust building. And as you know, that doesn't always happen when you're ready to, or when you need to publish by or anything else. So can you just give us a brief talk through for how that process went for the Baby and You survey, even if that leaps over from Healthy Moms?
Yeah, so at the very, very beginning stages of this process, so when we received funding to relaunch the program, one of the first things I did when I stepped back into this role was reach out to our tribal relations team at CDPHE. Most of the state agencies have a tribal liaison, and some state agencies have a team supporting that tribal liaison. And so we have a tribal relations team, which is now 2 people, but previously had been 3. And so we reached out to them to see what we should be doing to honor tribal data sovereignty throughout this process and include and start building the partnerships that are necessary to do this work over the long term. And so that was our first step. The second step was also connecting with the Albuquerque Area Southwest Tribal Epidemiology Center. They primarily oversee data collection and epidemiology support for the tribes in the Four Corners area. And so they actually include within their service area, the Ute, Mountain Ute, and the Southern Ute. And so they have longstanding relationships around data collection with tribal prams for New Mexico with those groups. And so we asked their advice on how to approach this as well. And as well as reaching out to the Urban Indian Health Institute, who are thought leaders and best practices for American Indian Alaska Native data collection. And so part of that was identifying that we needed to send notification letters to the tribes that this data collection was going to be occurring, and assuring that we will not be collecting a tribal affiliation or breaking down our data in ways that could potentially identify tribal people living on tribal lands. And then also we had meetings with several different more local organizations that serve American Indian Alaska Natives. So Denver Indian Health and Family Services, Denver Indian Family Resource Center, Denver Indian Center, to tell them about this project and see how we could tailor it to help support their needs. And then we also, as I mentioned, had that strategic planning meeting with our tribal partners at the beginning of March, where we identified what reciprocal and meaningful partnership would look like for them. There's still additional steps we need to take though, because connecting with the local American Indian Alaska Native serving organizations is not sufficient to understand the needs of the tribes. And then their needs and priorities may be entirely different. And so we're also planning formal consultation with the tribes. And then for our focus groups, some of that recruitment and engagement happened through those relationships that we built with local organizations. I also left out that we connected with the Colorado Commission on Indian Affairs and plan to regularly update their Health and Wellness Committee on progress with this and give opportunities for providing input into program decision making. And then another aspect of our recruitment for feedback was we reached out directly to our Baby and You enrolled cohort. This was like the most direct way that we could reach out to folks who were American Indian Alaska Native parents of young children, when it's a hard population to reach in general, let alone when you try to narrow. And then I do want to mention that for our focus groups, we did open it up to anyone who, because family structure can be different in certain American Indian Alaska Native communities where a larger familial network and group is supportive of that child. So we also opened it up to people who identified as aunties, uncles, grandfathers, grandmothers as well. All right, that was a very long-winded response.
Thank you.
But yeah, there are a lot of different pathways to and trying to connect with different groups because there are so many different interests and needs.
Thank you, Sarah. I'm now going to go to Alexa, who has her hand raised, and then we'll answer some of the questions in the chat. Alexa?
Thank you so much for this presentation. I am so excited about this. This is just excellent overall. I have two quick questions. The first one is there somewhere we can sign up to receive notifications about when your survey data is released?
Absolutely.
And then,
sorry, did you have a second question? I didn't mean to cut you off.
I did. And then the second question is, do you ever collect survey data on dads, especially if they are the primary caregivers? I saw some pictures of what looked like dads or like complete families, but I can't remember if you did say that you collect survey data on dads.
We don't yet, but that is absolutely something we're interested in if we can identify additional funding sources for that. And there is precedent for it. So a data collection system that you might be familiar with, the Pregnancy Risk Assessment Monitoring System, or PRAMS, that exists in most states, and it's a maternal and child health survey that's just at 3 to 4 months postpartum. Some states have done a PRAMS for dads that somewhat piggybacks off of their maternal sample. And so that is absolutely something that we could consider doing if we identify more funding. And we know it's of interest to our partners as well. I'm sure it's more broadly of interest too, but we know in particular for the Denver Indian Center, they have a fatherhood initiative that really would benefit from additional data on Native dads. But that is something that I'm sure could benefit other communities as well. So that's absolutely something that we have in the back of our minds as a way that we could expand this system moving forward if we're able to identify some additional sources of funding. And then your initial question was on signing up to receive notifications. I've noted your name so I can add you to that contact list, but also if you signed up through the Partner Advisory Network, let me see, go back to my slides and I can go back to that QR code. That is a way for you to sign up as well for our program updates and for any other types of updates you'd be interested in.
Very cool. Thanks so much.
Of course.
So Sarah, another question came in related to any plans of including immigrant population specifically in the sample. And that's from Priyanka.
Yeah, so we haven't considered that yet for sampling. We can somewhat get at that from whether someone is listed as foreign born on the birth certificate. That's an additional element we're going to need to request from vital records, but I think it's an important dimension and one that, like, historically we might not have been able to disaggregate by that, but with our oversamples, I believe we absolutely could. So we would have foreign born status, but we wouldn't necessarily know how long they were in the country. And we also wouldn't necessarily, actually, let me double check, that might be on the birth certificate too. But we wouldn't necessarily know whether they are, whether they're a citizen or here undocumented. And that is not something we are allowed to collect out of CDPHE. So it's just something that we kind of need to get closer to, but not precisely at, using the combination of information that we have on the birth certificate.
Priyanka, did that answer your question?
Yes, it did. Thank you.
Great, thank you. Lena asked the question about whether or not you can expand on the plans there are to incorporate community voices in the use of this data.
Yeah, so that would be through our partner advisory network and some of the connections that we've built. So what we had historically done for Healthy Moms was we would put out data tables broken down by several different demographic factors for all of our elements within our surveys. And that is still something that we're planning on doing for most populations, although we're going to work with American Indian Alaska Native partners to decide on how those are published. But then for any sort of data brief, that work is going to arise out of our partner advisory network. And also, like, when we don't think there's sufficient representation within the network on a particular topic area or on a particular priority population, we'll also be reaching out to community-based organizations to help identify first, what are our analytic priorities, not assuming that we know what those should be. And then also the form of how we should be putting out the data to make it most digestible, the content, and then the contextualization and interpretation. And we do not feel any need to own these data products or have them come out of CDPHE. We're happy to just be supportive of creating data products that are relevant to and rooted in the work of community partners. So I know that that's somewhat vague still, since we don't have the new data from BabyNU, but if you have additional recommendations on how you think we should be approaching that, please feel free to share, because we want to be responsive to what folks think is most appropriate.
Wonderful. Our last question then before we close is, there's a question related to proposals to submit. Are these proposals, for adding content to the survey?
Yeah, so for our open proposal process, that's for suggesting either specific questions that you believe should be added to the survey or general concepts that you think should be added to the survey. And so it's just a fairly simple form that allows you to fill out, go down either of those tracks, specific questions or general content or general concepts, and then just providing justification of why these data are needed, how they advance health equity, how they'll be actionable, etc. And so we are working on some resource documents to give example proposals, like strong example proposals. But then I'm also very willing, since I'm not a voting member, to work with anyone who wants to develop a proposal and help in the formation of that. So feel free to reach out if there's a topic area you're interested in, but you don't quite know where to start. We will have more materials soon, and we do plan on holding a webinar or just a meeting prior to the start of the open proposal process in June. We leave it open for a month. Well, it's continuously open, but we have a deadline of a month after we announce it. And so, yeah, I hope that answered your question, but if you have any other questions about the proposal process, I'm happy to answer offline.
Thank you. That was very helpful.
Sarah, we want to thank you so much. This was fantastic, and your responses to our questions were also amazing. I really feel like there's been a lot of thought that has gone into revamping the survey and inclusive involvement of community partners and different populations. Also, to all of our attendees, thank you for attending this initial session of Culture of Data and for engaging in the question and answer. It was just amazing. A few short announcements before you go. The slides and any additional handouts that Sarah may have will be available via Sketch. Some of you may have already seen, there is a PowerPoint slide on there. You'll also receive a conference evaluation by email after the entire conference is over. So please fill that out, even if you've only attended a portion of it. It's really helpful for us when we think about planning for the future for